Thank you. I think this is the most people I've seen awake this early in the morning. So I'm going to talk about the top 4 to 5 knee problems that you guys will see in your office or we see in our office. And then afterwards, there's a bunch of slides that I included that I'm not going to actually go over, but they're there just for your reference. All right, so why pay attention today? How many of you know what this slide is showing or have some idea? All right, well, maybe you guys all should have paid attention more in all parts of med school. I have no idea. But in general, I remember spending an inordinate amount of time at looking at red blood cells and poikilocytes and whatever those other things are, but never actually saw it even when I was doing my rotations, whereas musculoskeletal problems are extremely common and we don't cover them. About 1/3 of all visits to primary care offices are for musculoskeletal problems as their chief complaint. And musculoskeletal teaching, unfortunately, accounts for only 3% of medical school education at best. Only 1% of your internal medicine curriculum, once you've graduated and gone on to residency, has anything to do with the musculoskeletal system. And most primary care people, more than half, feel they weren't prepared for the musculoskeletal parts of their practice once they entered practice. And this was a study done by orthopedic surgeons a few years ago. And it's expensive. Ordering this MRI is going to cost somewhere between $3,000 and $10,000, yet we tend to use MRI as our go-to, and patients tend to want it just to see what's going on. So the goals for this presentation are to understand really common knee problems in a straightforward, systematic, evidence-based approach. We're going to talk about common symptoms that overlap, what imaging modalities to use and when, what the different treatment options are, and try to really go over high-quality literature. I found that patients really appreciate it if you say, I think you should do this because this study shows this, is a little bit better than I think you should do this because it just seems like the right thing to do. So the main things we're going to go over is our arthritis, meniscus tears, especially in the setting of early arthritis, patellofemoral or anterior knee pain, and some ligament injuries. So knee anatomy, thankfully, is relatively simple compared to all the other things that you all have learned in your life. And I think back to like the whatever the cardiac cycle thing, there's more things in one bump of an EKG than there is in the entire knee. So it's really awesome to only have to worry about like 7 structures. In general, anytime somebody comes in with knee pain, I really try to have our residents and anybody I'm teaching to go through it systematically in an anatomic-based approach. First and foremost, do they have a cartilage injury, whether this is an acute problem or is it more degenerative? Do they essentially have early or advanced arthritis? Do they have a meniscus tear? Do they have symptoms that came on after an injury and they're starting to swell? Could they have a ligament injury, whether to their ACL into MCL? Thankfully, this year is an early ski year, which is awesome. Every time engineers get on a bus to go to Tahoe, every orthopedic surgeon smiles inside. Could they have an extensor mechanism injury, whether it's an acute injury like a quad or patellar tendon rupture, or could they have something like patellofemoral pain or early cartilage loss underneath their kneecap? Other than that, all other knee problems are exceedingly uncommon. So you only really have to remember 4 to 5 things. So we're going to start with a case. This is a 56-year-old male. He has a 7-month history of kind of moderate knee pain. It's getting worse over time. He describes as kind of an achy, generalized feel. He did have meniscus surgery 4 years ago and felt like that really helped for quite a while. He used to run. Now he switched to biking. He got a Peloton at home. He's pretty excited. But he says he continues to have pain. It's near the joint line, not necessarily on the joint line, and it swells up. So what's his most likely diagnosis? All right, good. You guys are done. It's really nice outside. Go get on the bus going to Tahoe. All right, so arthritis is an extraordinarily common problem. I think we recognize how common it actually is. It's the most common problem that adults over the age of 65 actually face from a health concern. And the reason that is because they weren't designed to last 65 years. Your joints were made to last about 55, 65 years, and now y'all are keeping people alive to 95 to 100. So thank you, mostly. But as it's becoming more and more common, and the other thing we're doing is we're telling people to become become more active in their lives, which is mostly great. But as people have bought into this, they're realizing, well, I really want to be active, but everything hurts. So what can I do about it? I think one of the most interesting things is where we can explain a variety of different medical problems to patients very well, I'm always surprised at how few people actually understand what arthritis is. When I say, hey, by the way, you've got arthritis, they look at me like, yeah, I know, my grandfather had it. I was like, do you know what it is? Like, I got no idea. So the best way I like to think about arthritis, and this is a close-up of a knee, so this is an arthroscopic picture of your medial femoral condyle, and if we blow up what cartilage looks like, it has very little cells, very few cells, and it is very smooth. It is smoother than taking a piece of ice and sliding it over another piece of ice. It also has very few nerve endings, which is great until it's injured. And you think about your hand, which has a lot of nerve endings. If you get it close to a stove, you know it's hot. You don't put your hand in the flame. Cartilage acts the opposite way. Your cartilage basically says you have no problem, no problem, no problem. Holy crap, there's none of me left. Now you have arthritis. So we don't have any early warning systems until you've lost a fair amount of cartilage, which evolutionarily is great. From a health standpoint, is not ideal. And I found that the best way to describe this to patients is saying it's like you're losing tread on your tire. So when you have early arthritis, you've kind of lost a little bit of cartilage. Your tire looks okay. You're probably okay if you're on the right part of the tire. But eventually, when you've lost all the cartilage, your tire looks like it's about to fall off the car. And I do find that patients understand this better than any of the other explanations I've tried to give them. Now, the symptoms of arthritis you're all aware of. Patients will describe more of an achy pain, oftentimes in the morning, usually increases with activity. I think it's important to understand that these patients also will usually have a decrease in their activities, which unfortunately causes weight gain. And we know that at least a third of patients with chronic musculoskeletal problems have depression and or anxiety. So it's important to include these in, that these are probably interrelated. And if you think about this patient, this is exactly what he was describing. Twice. So on physical exam findings, I'm surprised that oftentimes patients seem to have a pretty normal exam. So oftentimes they don't necessarily look this bow-legged. This guy's quite bow-legged. He's totally worn out the inside of his knee. But oftentimes their exam is pretty normal. They tend to describe cracking or popping that's very consistent, or grinding. An occasional pop in the knee or a click is very nonspecific. As they get more advanced arthritis, they tend to have loss of range of motion, and they tend to be tenderness along the joint line, but also kind of everywhere near the joint line, especially on the tibial plateau. And this afternoon, we'll go over the differences of those in the small group sessions. When we get x-rays, we always want to get standing views, and the reason is arthritis is a weight-bearing problem. You don't have arthritis when you're lying down. You have it when you're standing up. So especially for your patients that have early arthritis, you want to get standing weight-bearing views. And this shows an example of somebody with mild arthritis, very little joint space narrowing, almost looks normal. Moderate arthritis, you can imagine there's not much cartilage, and then advanced arthritis, you essentially have bone rubbing against bone. Now, what about an MRI? And I think this is controversial. In advanced arthritis, first of all, if you suspect arthritis, please, please, please get an x-ray first. Look at that. If they have advanced arthritis, like the person that did on the right, an MRI is not going to help with diagnosis, and it's not going to help us at all with management. For early cartilage injuries, you've got a 35-year-old, x-rays looked pretty normal, absolutely get it. And then in people with early arthritis, I think it's kind of variable, especially if you've tried non-operative options for a while. I think it may be reasonable to get an MRI, but it shouldn't be your first line treatment or imaging study. And this was a nice study that was done a few years ago now in 2015. They looked at knee visits to orthopedics and primary care. They found that 25% of knee visits who went to ortho actually got an MRI, similar to primary care. Orthopedic surgeons tended to order MRIs for people who are a little bit younger and were more likely to undergo arthroscopic intervention. And surgeons were less likely to order over advanced arthritis, but both groups are still ordering too many MRIs. So this isn't just a problem with primary care, and part of this is consumer-driven. Patients come in and say, I would like an MRI, and sometimes you spend more time trying to talk them out of that MRI. All right, so the treatment options for arthritis, thankfully there's only 5 because I only have 5 fingers to show patients. If I show a 6, they get confused. And we're going to go over the evidence for all of these. The most important thing are the variety of things that you can do active in lifestyle changes, and that's for a few different reasons. First of all, arthritis is something that they're going to live with for an extended period of time. They need to buy into the fact that they need to take care of their own bodies. The first things that patients often ask are, well, what about these things I can buy at Costco? There's a huge vat of joint juice. Should I take it? Well, there's really good evidence from the NIH that shows that this is no better than placebo, and it's extraordinarily expensive. So I usually tell patients there's probably no harm in taking these, but there's absolutely no benefit, and we have a strong recommendation from the Academy of Orthopedic Surgeons that there is not good evidence that this is going to make your joints feel better or have a biologic effect. That being said, I know people who come in and say, I love it, it makes my joints feel good. I'm not going to tell them they're fools. I'm just going to say, okay, great, absolutely. If that's what's going to make you feel good, fine. Anti-inflammatories we tend to forget about. How many of you practice in the Bay Area? How many of you have patients say, I'm not a pill person, I don't like taking pills? All right, well, they should take Advil. It's a really good pill. Or, I try to convince my patients, take something homeopathic. If you really don't like Advil, take something that's homeopathic. But it works really well, especially if they're willing to take it for about 10 days to 2 weeks during an arthritis flare. And there's really strong evidence that decreases pain about 50% in most studies. The most important thing you can tell, how many of you practice in the Midwest? A couple people. Okay, totally different conversation there where we say everybody needs a little bit of weight loss. In the Bay Area, we're a little bit lucky. Most people are in pretty good shape. But the most important thing you can tell your patients who are overweight, meaning a BMI greater than 28 to 33, is that surgery will not lead to weight loss. Saying, I need a total knee so I can lose weight. It does not work. To be totally callous, it means you go from couch to fridge faster. You don't necessarily lose weight. But weight loss prior to surgery works really well. In fact, it may delay the need for a knee replacement. And that works for a variety of different reasons. This was a study that was done a while ago where patients who are morbidly obese underwent a gastric bypass, and they looked at collagen breakdown products 6 months before and then after surgery and found that your collagen breakdown decreased by about 50% and the knee pain got better. Now that you said that's great, most of my patients have a BMI of 28. What do we do for them? Well, this was a nice study that looked at activity and lifestyle changes where they did diet and exercise or just exercise. And early on, everybody got better in terms of their pain scale. But over 18 months, the people that did diet and exercise and lost a modest amount of weight, on average 10 to 20 pounds, continued to have significantly better pain relief. And I think that's both because of the biologic effect. Fat is a very inflammatory organ. So if you decrease the amount of fat, you're decreasing the amount of inflammatory mediators floating through your body. And two, the people who both are dieting and exercise are the ones that took control of their own health care. So this is the strongest recommendation that we can offer for this. We say there's a moderate amount of evidence that says that weight loss will lead to joint improvement without a biologic effect, which for orthopedic surgeons is like saying, please, this is a really good treatment. Well, what about physical therapy? I'm going to boil this down by saying that this was a really nice systematic review in the Annals of Internal Medicine. They went through every single physical therapy paper, and what they found was no single physical therapy intervention worked better than anything else. Whether it was aquatic, strengthening, aerobic training, any standard physical therapy worked pretty well to decrease pain and osteoarthritis of the knee. However, they found that the gimmicky things such as magnets, orthotics, ultrasound, the things that you kind of hear on the fringes of physical therapy didn't change how they did. So doing special physical therapy doesn't necessarily help. Physical therapy in and of itself does seem to help. There haven't been too many really nice studies done recently, but this was a study that was done now, a long time ago, 21 years ago, where they looked at patients over the age of 60 and they randomized them to aerobic exercises, resistive exercises, or no exercise at all. And they looked at daily function scores and pain scores and found that the patients who did the best, the take-home point with this, is the people with mild to moderate arthritis who weren't all that symptomatic on x-ray or physical exam tended to do a lot better than the people who had severe arthritis. So the patients who are essentially bone on bone, they're really miserable. Maybe sending them to physical therapy may not be beneficial, but sending the people who have mild to moderate arthritis are people who are going to do better with physical therapy. Now, what about orthotics, whether it's bracing or heel wedges or super feet for your shoes? Our evidence in orthopedics is that these don't work all that well for generalized osteoarthritis. If you have somebody with very isolated medial or lateral compartment arthritis, it may be worth trying an unloading brace. Those tend to be custom made. You have to send them to orthotics. I personally tend to use them in patients who need something temporarily, like I had a patient last week that had a trip to Patagonia coming up in a month, pretty considerable arthritis. She had already had injections, isn't ready for a knee replacement, certainly can't get it before Patagonia, was not willing to give me her tickets to Patagonia. So I said, okay, we'll try a brace. Now, what about injections? How many of you perform injections at some point in your office? Okay, good, awesome. It'll be everybody by the end of this. So the things that patients come up most and ask is, well, what are the risks of doing these injections? I've heard they cause arthritis. I heard they cause diabetes. I heard they may turn you into Barry Bonds. There's a lot of confusion around corticosteroids. I know I need to change the slide. There's many more steroid users, but nobody used them as well as Barry. So what we found, we've done a variety of different studies, both in our lab as well as at Stanford and other institutions. And what they've shown is that the steroid concoctions that we use, the steroid itself doesn't really do much of anything. It's more the volume of acidic anesthesia that will kill cartilage cells. So we really try to minimize the amount of anesthetic that we use. I only use about 2 or 3 cc's rather than where I used to put 10 or 15 cc's in. And I tell the patients it is probably safe if we're using this as a temporary solution. It is not going to make your head get big, other things get small. You're not all of a sudden going to win the Tour de France. In terms of data, the best data that we have comes out of the Cochrane systematic review system. And in general, if you look at these many studies over many years, this came out last year, 2 years ago now in the Cochrane review, is overall most studies for pain control tend to favor steroid over placebo a little bit. It tends to work a mild to moderate amount. In terms of long-term pain relief, this is at 6 months now. Again, overall mild to moderate relief with steroid over control. So that's what I tell my patients. Steroid injections tend to work for about 3 to 6 months. It's not biologic. It does not improve the amount of cartilage you have, but it does not mask pain. Patients always say, I don't want a steroid injection because it masks pain. It doesn't. The numbing medicine that you get for the first 4 hours masks the pain, just like you had a lidocaine shot when you go to the dentist. But the steroid is a potent anti-inflammatory that'll decrease the amount of inflammation in your knee. Okay, what about viscosupplementation? So this is the Synvisc, the other hyaluronic acids. These people are happy. I mean, I have never seen happier people in an ad. I mean, he's got his khakis going on. He's going with a little bit of flair. There's nobody happier than a hyaluronic ad patient. This is also my second career. When I retire from medicine, I'm going as a clip art person. It looks awesome. These people are happy. So viscosupplementation, we don't know exactly how it works, which adds to a little bit of the confusion. We say it lubricates and cushions the joint. It tends to decrease pain-related mediators within the joint. And we say things kind of along the lines of, well, the molecular weight of your synovial fluid goes up. There's more lubrication. It's like a jello. But bottom line is we don't know exactly how it works, but that's probably okay. Who does it tend to work for? It tends to work for people with mild to moderate arthritis, tends to work for people that are already kind of buying into something but need something a little bit more, and people who are willing to change their activities. What it does not do, it does not turn this lady into somebody who's super flexible. So I would have modest goals with this in general. Now, it depends on who you ask on how effective this is. If you ask the Academy of Rheumatology, they say it works really well. If you ask orthopedic surgeons, we officially have come out against hyaluronic acid injections because we think it's too expensive for the value that you actually get. And the reason is because we can do something a rheumatologist can't. We can still replace a knee. They can just refer to us. So I think there is some implicit bias in these recommendation statements. This was a study out of New England Journal of Medicine who came out basically saying the current evidence base does not advocate the use of intra-articular hyaluronic acid for the management of knee arthritis. So when the New England Journal says something, I tend to almost kind of read the summary. But I think this is pretty important in saying that this may not be the best option for us. In terms of other things that are coming down the line, how many of you have heard of PRP? How many of you have used it yourself? Yeah, doctors tend not to use it. Interesting. It's working on my hair, but other than that, not so much. So this was a study done. It was a systematic review of overlapping meta-analyses, which I don't know exactly what that means, but I think it's a systematic review of systematic reviews when all the systematic reviews are done. But what they found in this summary was it tends to work better with people with mild arthritis, and they said that although there's limited data, it's mildly promising. Well, what about a good study? Well, this came out of Rush, which was one of the major orthopedic centers 2 years ago now. They did a prospective double-blind randomized trial comparing the intra-articular biology, saying they measured some functional assays of PRP to hyaluronic acid. So they're smart. They picked a thing that doesn't work very well to compare to. But what they found was that from month 6 to 12 especially, there was more improvement in the PRP group compared to hyaluronic acid. And the patients that did well, when they did the subgroup analysis, the people that really decreased their inflammatory markers were the ones that did well. So there are some people that may benefit from having PRP injections. And overall, that's what the literature shows in other systematic reviews. When you compare PRP to either steroid or hyaluronic acid, consistently PRP shows up working a little bit better, even in double-blind studies, than other injectable agents. The problem is, as of now, very few insurance companies actually cover this. Surgery doesn't work. So if you have arthritis, we know from multiple studies that are really well done. I would encourage you guys to read either of these two in New England Journal. Surgery to clean up the joint, except for in very rare instances, does not work, so don't do it. Knee replacement is the final common pathway for everybody with moderate to severe arthritis. We essentially, I like to say it's a knee resurfacing and not a knee replacement. Patients think we're going to take out the whole middle half of their leg and put something else in. We shave off just little bits of bone and cap it similar to how you would do a crown. This tends to work exceedingly well. We replace the cartilage surface with metal and plastic. It is made out of cobalt. How many of you saw the Netflix thing on cobalt, bleeding edge? Okay. Yes, we do use cobalt. No, it doesn't cause everybody to go crazy, but I highly recommend watching it. This is what the x-ray looks like afterwards. Overall, it tends to be an excellent procedure for low to moderate demand patients. Pain relief is immediate. Patients feel different right after surgery. 90 to 95% good to excellent results at 10 to 15 years. So I tell patients that when you've tried everything else, yes, this is worth doing. It makes you extraordinarily happy. All right, second case. 35-year-old basketball player makes a rapid pivot on his fixed leg and feels a tearing sensation in his knee. He tries to continue playing but has a moderate amount of discomfort in his knee along the inside of his joint. Knee swells over the next few days. Notes pain along the joint line with squatting, climbing up and down stairs. What's his diagnosis? Wow. All right. Jeez. All right. I think you guys were looking for it in the syllabus. All right, so meniscus tears. We're going to go through the rest of these a little bit faster because I think I really want to highlight how important arthritis is. But meniscus tears are one of my favorite injuries because I have a lot of them, for me, not other people. So classically, patients will describe this a little bit differently than ligament injuries. These are the people that I had an injury, I felt not quite right when I was playing soccer or basketball or skiing. I finished the day. I was able to continue skiing, but that evening on the drive home, my knee got kind of swollen. I woke up the next day and it was kind of stiff and swollen. The main thing is oftentimes with a lot of meniscus tears, they keep playing, same with cartilage injuries, whereas ACL tears, they stop, vast majority of people. Physical exam, we'll go over how to do this both in another talk this morning and then this afternoon. I go in a 4-step process. I check joint line tenderness. If they are tender right along their meniscus and their history sounds like meniscus, I stop. That's enough torture for the patients. If that's negative or equivocal, I'll do a Thessaly or Apley's test, which we'll go over later. If those two are negative and it sounds like a meniscus tear, I'll have them get into a catcher's position. And if that's negative, I'll have them kind of bounce up and down. It's called a duck walk. If all those 4 are negative, the chance of them having a meniscus tear that's symptomatic for them is very, very low. For people with suspected meniscus tears, especially acute injury in your younger people, for meniscus tears, younger means less than 50, I do tend to get an MRI relatively quickly. This is an example of a normal knee with a with no meniscus injury. This person happened to have an ACL injury, but the meniscus was okay. And this is kind of a typical meniscus injury for a middle-aged person. He has a horizontal tear, so this white line that comes all the way out to the surface of the joint is a meniscus tear. So my general algorithm when I'm in clinic goes something along the lines of this. So depending on whether it's an acute injury versus a chronic injury. For the acute injuries, active, younger, under the age of 50, they like to ski, they like to play tennis. I, in general, want these patients referred because I am going to talk to them relatively early about the advantages and disadvantages of surgery. However, most patients that come in tend to have chronic injuries that's been going on for a while. If they're an active older person, I'll usually say, well, most studies, which we'll go into in a minute, you tend to get better with non-operative management. Let's try PT for 6-8 weeks and see how it goes. If not, let's get an MRI. If they're sedentary and older and they have any evidence of osteoarthritis and over 65, I try not to get an MRI because surgery very rarely is going to be all that beneficial, and physical therapy usually is beneficial for them. However, if they fail physical therapy in any of these groups, I think it's reasonable to consider sending them over for evaluation for surgery, which may be an MRI, may be more x-rays. Now, what about for degenerative meniscus tears? The patients that describe these chronic pain, you get an MRI and it says they've got a complex meniscus tear. Most of the evidence suggests when you compare surgery to physical therapy, for the patients that do well, they do equivocally well, and that means they're back to their normal activities in about 90% of patients. In these studies, about 30% of people fail physical therapy, meaning they don't feel better enough, and they cross over and do surgery, and those patients tend to catch up by the end of 1 year. So that means there's no reason to jump to surgery unless there's a logistical reason for most patients with degenerative meniscus tears. And patients love to hear that. You get to say, hey, you may need surgery down the line, but there's a really, really good chance, there's a 70% chance you get better with physical therapy and avoid the whole surgery thing. And if you don't get better with physical therapy, you'll still get better just as well if you have surgery in 3 months. So I think that's a really important take-home point for your patients, especially with the ones with degenerative meniscus tears. And then this study said essentially the same thing, and again, New England Journal, important to actually pay attention to. Partial meniscectomy versus sham surgery for a degenerative meniscus tear, there was no differences at 1 year in these treatment groups. So doing surgery is not this panacea that works for everybody, but it tends to, for the right patients, it does tend to work pretty well. In terms of what we do with meniscus tears, this is an example of somebody with a kind of a big meniscus tear. This one had flipped underneath his meniscus and was pretty symptomatic. We tend to take out just the torn part. On average, that means we take out 10 to 15% of the meniscus. This piece of meniscus is biomechanically not doing anything for you anyway. Taking out the meniscus probably does not, therefore, change the natural history of what's going to happen to the knee. The more meniscus we take out, however, the more likely it is that they develop arthritis. Okay, so the outcomes of meniscus debridement overall are really, really good. This is a low-risk procedure for a vast majority of patients. Again, pain relief isn't immediate. When I had my meniscus tear, I felt instantly different within about 48 hours after surgery. So not instantly, quickly different. You tend to have normal range of motion, and long-term results are very good at 10 to 15 years. So 90 to 95% patients are doing well. Patients have an 80 to 85% chance of return to play at their previous level of sport. So there are two things we want you to focus on not to miss. First is a bucket handle tear. So that's when you have a big piece of meniscus that flips into the center of the knee. This is going to tend to cause a locked knee. So you tend to see this with more severe injuries, but we just had a plastic surgery resident who was on call for plastics. I don't know what actually happens. That's an emergency. But he was getting off his couch and his leg locked at 70 degrees. And for about 3 days, his leg could go from 60 to 70 degrees, and that was about it. And he has an entire lateral meniscus tore and flipped into the center of the knee. That's something that needs to be treated sooner rather than later. So somebody who cannot get their leg straight with even what sounds like not the best injury mechanism. He literally was getting up off his couch. These need to be seen sooner rather than later. And the other one is a meniscus root tear, and these are a little bit tricky. These are when you tear usually the medial meniscus off the very back attachment. And the reason why these are important is they don't present like typical meniscus tears. They tend to have swelling. They often describe an achy period before the knee actually got injured, and then they will have said they stepped funny and they had immediate swelling. These patients tend to be in their 50s to 60s. They tend to be about 65% are female. They tend to be a little bit fluffy, but when you examine them, they're not that tender along the meniscus. They're just swollen. So if it sounds something like a root tear, please get an MRI and refer them to us sooner rather than later. The reason is when you've disrupted that root, it's essentially your body saying, I took out your entire meniscus in one step. If we don't treat these within the first 6 to 8 months, the risk of arthritis, degenerative arthritis progressing quickly is about 70%. Okay, and this is relatively new. We didn't even really know these existed until 2010. This is just an example of somebody with a bucket handle tear. This is your condyle. This is your meniscus sitting in front, so every time you go to straighten your knee, that blocks you. This is an example of a meniscus root tear. So this is the back of the knee. This is your medial meniscus. It's coming over, and it's not quite attaching there. All right, so next case. So 41-year-old, adequately husky male, presents with bilateral knee pain, but mainly left more than right, has anterior knee pain with stair climbing, long walks on the beach, and sitting for long periods. Sometimes he says he feels weak, as if it gives out. He says it almost feels like his friend who had an ACL tear, where it buckles on him. He has a little bit of swelling occasionally. He says it's kind of all over the knee. So what's his diagnosis? Awesome. Good. Okay. Ooh, fancy. Okay. So patellofemoral problems are the most common knee problem I see that's non-surgical. Tends to be often a bilateral symptom, but usually patients will pick one leg more than the other. Tends to be pain anteriorly and anteromedially, kind of on the inside of the kneecap. The question I usually ask patients, is it worse going up or downstairs? Patients with classic patellofemoral pain will say, oh, downstairs or downhills is really bad. Uphills, not so bad. Is often associated with changes in activity. I would love to say it's usually more activity. Unfortunately, it's usually less. So the classic patient I see is, I was doing well in college, I exercised a lot, I got a job in tech, now I didn't exercise, now I go to boot camp and my knee hurts. And their mechanism isn't usually all that specific. Usually their mechanism is something along the lines of, I twisted a little bit funny, or I banged my knee and since then I hurt it. It's been hurting. Not something that you would really suggests something that's severe. So physical exam is hard because there's not anything that's really specific. They tend not to be swollen. They tend to be able to squat down. But the test that I really like to do is a single leg squat. And this is an example of somebody with a single leg squat that's not so good. You can see she can barely stand on the leg, and when she goes to even balance, her leg's really wobbly, and she has to shift her entire trunk over. And I encourage you to try this on yourselves in front of the mirror and see how good you are. An average person is not that much better than this, but you should be able to keep your hips level and bend your knee to about 45 to 60 degrees, and you shouldn't feel like you're all that wobbly. So patients that are this wobbly around the knee probably cause micromotion and irritation around the front of the knee, and imagine what that feels like when you're walking on stairs or jogging. Those sort of things are just accentuated. So the etiology for patellofemoral pain, there's both non-modifiable risk factors, things I tell patients, yes, you may have these, but also things that we can modify. So non-modifiable, they're a little bit knock-kneed. They tend to have small trochlea, and they tend to pronate their feet. All things I'd say, don't worry about it. Lose weight, get your core stronger, work on flexibilities. And then depending on what their activity is, either shoe fit or bike fit is important. So oftentimes we'll have patients in the area that do a lot of biking. They increase their activities or they get a different bike. They didn't fit their bike. They're sitting too far back. All you have to do is tell them to go to Sports Basement, get their bike fit for them, and all of a sudden their knee pain goes away. Whether or not to get x-rays, we almost always get x-rays for patellofemoral pain. I very rarely get an MRI because it'll often be read as like mild chondromalacia, which has not been correlated with symptoms, and it doesn't really change my treatment options. So I really try to encourage my patients with anterior knee pain, if their x-rays are relatively normal, don't proceed to get an MRI. MRIs can be beneficial if we're thinking about surgical planning, especially if they have patellar instability or they failed non-operative options. But other than that, they don't really play a role in patellofemoral pain. The mainstay for treatment for anterior knee pain is physical therapy, and the reason is it works. It works for about 80 to 85% of patients in large studies. So the studies I'm going to cite all have large number of patients. Anybody who did physical therapy did well, but the people that did core and hip stability exercises, kind of ignored the knee, tended to do better. And their improvement was pretty quick. It was either at 6 to 8 weeks. So what do I write for physical therapy? When I write the prescription, it says work on knee range of motion, sure, but focus on hip and core stability exercises. Focus on a return to play to sports and continually assess them with a single leg squat. And that tends to get a majority of patients with patellofemoral pain feeling better. All right, my favorite topic of the winter is what people do to themselves all winter long. Okay, so 42-year-old financial advisor, he's an advanced skier, it says so, it says expert, comes in after skiing at Boreal, sure you're an expert. He says he caught an edge, had a grinding feeling and he fell, tried to ski but he couldn't. He was tobogganed down and his knee swelled up on the way home. What's his diagnosis? This one's easy, give him like 4 seconds for this. Somebody please pick E. Yeah, good job for the 4%. All right, you guys get free conference next year. All right. So an ACL injury is the most common ligament injury that we see in kids. It's second only to adult MCL sprains in adults. That's a little bit redundant. This is a normal ACL on MRI. This is a torn ACL. When you have an ACL tear, 90% of the time it's a complete tear. MRI is extraordinarily sensitive and specific. It will diagnose an ACL tear 95 to 99% of the time accurately. History tends to be a non-contact twisting injury. It tends to happen in skiers because you have a 162 centimeter fulcrum on your leg that's going to twist your knee inside to the inside of your knee. Snowboarding, uncommon. They usually have to land really awkwardly and hyperextend off a jump. About 70% of people will hear a pop or describe that grinding feel in their knee. Swelling will happen within an hour. And importantly, usually they won't return to play. But if they wait a few weeks and the swelling's gone down, they often will be doing pretty well by then because they haven't gone back to sports. Their swelling's down. They don't have a lot of pain. So be wary of those patients that have a history that sounds like it might be an ACL injury. On physical exam, Dr. Allen gives a great physical exam talk and great demonstrations, and come to the hands-on talks later. Your benchmark is a Lachman test, which tests the anterior instability of your tibia relative to the femur. This person's pretty unstable, but by the end of today, you all should be able to get a decent Lachman, if not on each other, at least on children at home. Okay, x-ray is often non-diagnostic, but the reason we get it is because if somebody fell down skiing or snowboarding or playing soccer, we don't know what they had. You want to rule out fracture, make sure they don't have a tibial plateau fracture, and every now and again you're going to see a little fleck of bone over here where the capsula avulsa is. This is called a Sagan fracture. You can tell them very smartly, 100% chance you have an ACL tear if you see that. So 100% if you see that. MRI findings, we kind of already went over. Your primary sign is the ACL is torn. You have swelling. You'll also see a bone bruise pattern on the outside of the knee, so you'll get bruising in the back of the tibia because your tibia, essentially almost dislocated, hit the femur and caused the bruising here and then slid back into place. So that's what we think that pop and that grinding is that motion of the outside of your leg. So the treatment options for ACL tears, not everybody needs an ACL. ACLs are important for cutting and pivoting sports, soccer, basketball, tennis, hardcore hiking, skiing, probably snowboarding realistically. Not necessary for people who jog, who are low activity. They went up skiing once with LinkedIn. They will never go again. They may not need an ACL. The rationale for younger people is that we know that people with ACL tears are at higher likelihood for meniscus injury and cartilage injury, especially if they try to go back to sports. So my general breakdown is under the age of 40, you're probably getting an ACL reconstruction. Over the age of 40, it depends on your activities. Over the age of 60, you better have a good reason to convince me for it. It's pretty rare for us to do an ACL reconstruction over the age of 60. This is what a new ACL looks like. This was supposed to be a video, but it got lost. This is new ACL. It's really, really pretty. It's a really fun surgery. For doctors, not so much the patients. So there's a lot of data, but I really want to focus on the outcomes of ACL injuries in older athletes because that's what we tend to see. And there's been some good literature on this in the last 5 years. So this is a paper that came out of Europe. They looked at outcomes of ACL in older patients, which meant over 40. It's Sweden. They were all skiing. But what they looked at outcome score between the younger and older patients and found actually both groups are actually doing about the same, which was really nice. You can tell your older patients, you are going to recover, you will do okay, you will do as well if we ask you knee function scores as well as your younger cohort. This is a separate study that came out 1 year prior. They looked at an average age of 52 years. Almost 90% were satisfied and 90% returned to sport. Remember, however, they probably are a little bit lower demand than your 20-year-old recreational club players. So in general, what I tell patients in higher level patients, it's okay to consider an ACL reconstruction, but doing this at Jackson Hole is still a bad idea. Please do it, though. Good. So in summary, for arthritis, know the 5 good treatment options for arthritis. I go through all of them with my patients every single time. Know who will benefit for meniscus injuries. Know how to diagnose your ACL injuries and what the indications for surgery are. And for patellofemoral pain, learn to recognize it and really encourage your patients. They will get better with physical therapy. Thank you.